All right, welcome everybody to our visiting professor series. My pleasure to welcome our visiting professor Lou Pasquale, who I will give a formal introduction to right before his talk. Just a reminder, if you're on Zoom, please mute yourself. If you need help, please reach out to the chat box and Steve Crawford will give you a hand navigating system. For CME, look for an email on Monday or Tuesday, complete the survey, and then you should see the credit appear sometime in February. The activities approved for an AMA, PRA, category 1 credit only, which is applicable to the following physicians, full credit, New York State and Pennsylvania optometrists, which get full credit. Some nurses and ophthalmic technicians may be able to claim partial credit. I don't know about genetic counselors. We should figure that out, Steve. Questions about credit can be addressed to Stephen_Coffin at urmc.rochester.edu. Here's the disclosures today. I'll let you read them from Dr. DeAngelis and Dr. Pasquale. And our disclosures are listed here. The accreditation is the University of Rochester School of Medicine and Dentistry. Is accredited by the Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians. The certification is for, again, 3 AMA PRA category 1 credits. Financial relationships of the planners, presenters, and others are listed here. This is our tentative schedule. We'll see pretty much we'll start with our spotlight by Dr. DeAngelis, have a question and answer session, followed by 3 case presentations by our residents, and then the visiting professor lecture by Dr. Pasquale, followed by a short question and answer session. So it's my pleasure to welcome the research spotlight, which will be presented by Dr. Margaret DeAngelis, who's a professor of ophthalmology and the Ira G. Ross and Elizabeth Olmsted Ross Endowed Chair at SUNY Buffalo's Jacobs School of Medicine and Biomedical Research. Dr. DeAngelis' research program utilizes systems biology-based approach to understand disease mechanisms in both Mendelian and complex blinding conditions, including age-related macular degeneration, glaucoma, and diabetic retinopathy. This translational research is funded by the NIH, private foundations, and the pharmaceutical industry. She's ultimately focused on identifying mechanisms and targets for treatment of these disease areas across their stages of development. To enhance translational efforts, her laboratory and colleagues have created a well-characterized fresh human donor eye bank of ocular tissue, blood, serum, and plasma. Using this resource, contrasting healthy eyes with diseased eyes has helped delineate potential disease mechanisms. Dr. DeAngelis has published the only standardized phenotyping protocol for human donor eyes specifically used for biochemical and molecular studies. The success of the eye bank is dependent on close collaboration with ophthalmologists. She has over 100 publications, serves on several journal editorial boards, and serves on steering and leadership committee for the International AMD Genetics Consortium, sponsored by the NEI, and also the Scientific Oversight Committee for the Global Eye Genetics Consortium. She also chairs and serves on several NIH study section review panels of the Department of Defense and the Foundation Grant Review panels. She has received her master's in physiology at the Medical College of Virginia and went on to complete a doctorate in neuroscience at Louisiana State University Health Sciences Center. She did her fellowship training in human genetics, statistics, bioinformatics, and ophthalmology and epidemiology at Mass Eye and Ear Infirmary. Please welcome Dr. DeAngelis as she presents Understanding of the Genetics of Glaucoma Medication Non-Adherence.
Thank you so much. Thank you for the introduction and very much for Dr. Allison and Dr. Villarento for the invitation to be here today. Can everybody hear me okay? Okay, great. So we're going to do a brief overview on what is the challenges and how we went about studying the glaucoma, genetics of glaucoma non-adherence, our study design and our data analysis in a pilot study that we published upon, and now that we're working on along with Dr. Allison here to study a more diverse population, much larger population, to try to get at biomarkers to study those at highest risk for not taking their glaucoma medications. as most of you already know, as many of you are clinical experts, the scope of the problem for medication non-adherence in chronic conditions that are very similar to glaucoma is greatest in patients with chronic conditions. And like glaucoma, diabetes, blood pressure, and hyperlipidemia. And it is estimated, this has been well established for years, and there's a good review on this in the New England Journal of Medicine, that $100 to $300 billion could be saved per year if people just improve their adherence by 30%, 30 to 50%, just took their medications as prescribed across all chronic disease states. And I'm not talking about cancers here. I'm talking about chronic conditions that usually one has before they show up in the clinic usually, and that they're not aware of. And as all of you know, I don't need to tell you, and there was probably 3 studies published in the 90s where there was actually showed that people who did not take their glaucoma, maybe early 2000s, did not take their drops as prescribed, actually showed worsening vision loss and neurodegeneration due to glaucoma. Those studies obviously wouldn't be pass an IRB nowadays. And just to give you an idea, if you were to look at the CDC's website, the scope of the problem is pretty large. So maybe glaucoma only affects a small portion of the population, and then depending which race you look at, the numbers, there's an increase in prevalence. But regarding chronic conditions, age 55 and over, at least in the United States, you have 78% of the population with at least one chronic condition. And as you look at the aging population, you at least have nearly 86% of the population with one or more chronic conditions. And not just these are papers from our group, but with other groups, the range is comparable across disease states. And we've shown this with asthma, embolism, and other drugs, and it ranges anywhere from 41 to 71%. And despite what measures you can use, it's consistent across chronic disease states. So this is just our work that we did mostly when I was in Utah, along with Michael Feehan and Alan Crandall and the School of Pharmacy. And then, as most of you know, barriers to adherence are numerous. And despite best efforts with clinical research, and perceptions of risk, people know they're going to go blind or they could go blind. And even when those barriers are not present, people still remain non-adherent. So could there be genetic and biological factors at play that increase one's predisposition to this? And we're certainly not the first to think of this. There's other people, there's one other group that published on this. And this paper was published nearly 10 years ago. And while this group, this was done on Korean women, about 500, did not attain statistical significance at a big genome-wide level, they did get some suggestive significance. And this group proposed that they would find things that were affiliated with personality disorder. And why they didn't find anything, they found potential candidates that were suggestive of that there could be a role for genetics in height, and explain why people didn't adhere to their high blood pressure drugs or their diabetes drugs. So this was suggestive. However, they did not calculate what the component was due to genetics. And I'm going to talk about that later. Just because you run a genetic association study doesn't explain that there's a genetic component underlying condition. And what I'm going to talk about today is what we found that was statistically significant. And this is just published this year. And by multiple expertise coming together and publishing this small pilot study. So what we started out to do is we had access to the Marshfield Clinic healthcare system. And some of you are probably aware of the system. What's nice is that it is a very homogeneous system. So that means that it's a good system to take a look at because you don't have a lot of variables that you're controlling for initially. And it's also a closed healthcare system. So patients are getting their diagnosis and filling their prescription all in one place. So that makes it kind of nice. It's almost like the VA system. So you can take advantage of the clinical health records. So the demographics of the population, or for the data we used, were all white, non-Hispanic, smaller number of males, and the age range is seen here with the average age being 78. And only 200, though we had access to a lot of data, only 230 patients met our criteria, and you'll see why. So we have to figure out what's the threshold for measuring who's adherent versus non-adherent. And some people use a cutoff of 70%, some use 100%. We used a cutoff of 80% because that is what we felt based on our research and what we've done is if you're greater than 80%, you're taking your drugs 80% of the time as prescribed, you're adherent versus less than 80%, you're non-adherent. So that was our cutoff for glaucoma medication non-adherence. And then we used two measures, which are complementary, but they're different. And we feel this increases study rigor. A lot of the time you'll read people use the medication possession ratio, which tends to inflate the findings because it doesn't, if people get their scripts or prescriptions filled earlier, it tends to inflate. You can have, you'll see over 100% rate adherence, and you don't have over 100% adherence, where in proportion of days covers is a much more conservative measure. So it's nice to have complementary measures and be able to look at the overlap between the two and the differences between the two. We used both. And at the time, because we looked at we looked over a 2-year period, the time there was ICD-9 codes, and we worked with the pharmacist, the PhD, PharmDs, and the pharmacist to classify the common medications and used insurance key methods. And we also looked at refills made outside the Marshfield Clinic to capture as much of the data as we could. So this was the prevalence of non-adherence. And just getting to the point, it was in line with what we previously others had identified, that the more conservative code, we found a higher prevalence of non-adherence at 67% in this small sample size and 59% using the less conservative method. And non-adherence was higher we found in men, which has been published before by us and others, and patients that were younger, males that were younger, and in females were more likely to be non-adherent, which is already known in the literature. So that was good. It was a way to validate what we found in this homogeneous set for Marshfield. So we had genotyping data on these patients, but what was interesting is we had whole exome direct sequencing. So we were capturing all the coding regions, or what people like to think, the important regions of the genome, but the non-coding regions are just as important as we are all learning. But it was nice to have direct sequencing information because we got a lot, I will tell you a priori, we got a lot of information from both ways of doing this. And even though we had data for all, like over 1,000 samples, we only had information of what we needed on 230. So that's what we worked with. But before we start doing association, and as you'll hear from Dr. Pasquale later, and you've read on other papers on age-related macular degeneration, and you will on other complex diseases, you want to calculate a hereditary component, because as many of these diseases, you have environmental factors, you have genetic factors, and you have the interaction of those factors that aids in bringing about that condition or risk of that condition. So we wanted to say, hey, is there even a genetic component to this condition? So we want to use those variants to say how much of not adhering to your medication is due to even a genetic condition. Ideally, you want to use twins. You want to use fraternal twins and identical twins. And you would like to see that the concordance rate is greater in identical twins as opposed to fraternal twins. But we don't have that here. So you can use unrelated case controls. So we did that here. And I'm not going to go into all the metrics we used. We used 3 different methods. But suffice it to say, we found a large proportion was attributed to a genetic component. And almost at least 50% using a more conservative approach and over 50% using the less conservative approach. But what we noticed is this is in line with other psychiatric conditions, including smoking behaviors, alcohol dependence, and post-traumatic syndrome. So it's in line with other psychiatric disorders that colleagues who worked with us on this paper have seen in their work. So that gave us confidence that we were moving in the right direction. But again, appreciate this is a small sample size, and we used our non-coding and coding variants to calculate this. So given that, I won't get into it, but we did power calculations also to make sure we had enough of a sample size. And I'm going to just show you the results from the coding variants. I will tell you nothing from the GWAS, the genome-wide association, surprisingly was not significant. And also we did not have power to detect at the genome-wide significant level. We only had like 60% power. But we had some interesting findings, again, that will have to be done in a larger sample size. And even after Bonferroni correction or correcting for multiple tests, we still got correction for these interesting genes that we uncovered. And we found protection and genes that increased risk. And one was in common, and it was the same variant, and it went in the same direction. So the variant in this one gene, which you'll find what it does later, was that it increased risk. So what you want to do is start to tease these genes apart, their variants, because all these are coding variants. and see and do an in silico type of analysis, use tools that try to give functional meaning to these genes. And in doing so, we found that two of the genes were interesting. One was involved in smoking initiation, one was involved in detoxification of drugs, which was interesting because maybe it has to do with the way medications are metabolized. And interestingly, the CHCHD6 that was in common is involved with Alzheimer's disease pathophysiology. So variants in this gene, not the same variant, but a different variant, are involved in cognitive decline. So maybe that has something to do with non-adherence. And this is interesting because the genetics, there has been papers to show that there is genetics associated with financial decision-making. So it kind of fits in, but it needs more work here. But most importantly, as with any of these large genomic studies, you want to examine genes in aggregate. And this is what major drug companies do to try to see where to pinpoint to start, where do you start designing drugs? And do you design drugs or medications to 3 genes at a time, 1 gene at a time, and where do you design it? This is what we're trying to do right now for age-related macular degeneration with some of our findings. And this is just an example looking at a network for the proportion of days covered. And these are genes from our network. And what an example, this is using ingenuity pathway analysis, is trying to look at the direct and the indirect, which are illustrated in a dotted line, and more of the direct. These are hypothetical based on what is known in the literature, and these are more direct interactions. And it starts to get you to think. And this is actually down here, this Atom S5, and Dr. Pasquale certainly knows more than I do. This has been implicated not from a genome-minded association study, but from gene expression studies with glaucomatous tissue from the lamina curvosa. But the variant driving the expression has not been uncovered. So, but to the best of our knowledge, none of these genes that are highlighted here have been associated with risk of glaucoma that we know about. And then this is some of the markers of pathways. Then this is just showing that this is significant. These pathways are significantly associated with risk of not adhering to your glaucoma medications. And I also want to make the point that the genes we found don't explain all the heritability of risk. It just means that there's a genetic component. We don't know how much the genes we found explain that heritable component. It's just saying that there's a strong genetic component as to why people don't take their meds. It's not saying that these genes explain it, and we have to replicate these genes. We haven't replicated them. So in summary, we found that prevalence of non-adherence is high. That's not surprising. Us and others have found this, but we saw it in this small group. And we were the first to show substantial levels of heritability of glaucoma. I just saw another paper. It's not been peer reviewed yet, but it's up on BioRVX or MedRVX. And they did calculate heritability. It was done on, I think, the UK Biobank and a Finnish biorepository. And I think it was for breast cancer and diabetes. And that we found both protective and risk genetic factors for glaucoma medication and non-adherence and biological pathways. And what this might suggest is maybe with people with certain risk scores, and we're certainly not there yet, may need closer follow-up for having to take their medications. And future directions and what we're doing now with, certainly with Dr. Allison, is looking, we're doing this right now with the VA data set, is looking at a much more inclusive study, looking at Black and African Americans within the United States, Hispanic individuals, and trying to see if there's other variants that could explain the lack of adherence, because in our own studies, we have found that Black males, younger Black males, are the least adherent group, at least in our published studies. And we need to do the structural equation modeling to really look at some of the behaviors that influence lack of adherence to glaucoma drugs, because there's certainly been papers published by a lot of folks that say there's a higher risk, certainly in those with PTSD and other behaviors. And I'm sure some of you may have published on this, that could influence being non-adherent to medications. And these are my wonderful collaborators. I couldn't have done this alone. I want to call out Michael Fian, Julie Barr, Trifa Shawnee, John Lilvis, and the folks at the Ross Eye Institute, and certainly Dr. Allison here at Rochester, University of Utah. I want to call out the late Alan Crandall, Mark Munger, Leah Owen, and certainly Murray Brilliant, who's retired, but from the Marshfield Clinic. And the funding for this study, because this is bootstrapped in order to apply for funding to get more funding. So, and Leah and John, who are on mentored awards for this. So thank you, and I will take any questions. Oh, yes.
Meg, so
Yes,
it's
slowly.
very challenging phenotype to find a genetic profile for. I congratulate you on this effort. And it's so hard to sort of make these bigger because, you know, in Marshfield, you have data on adherence, and, you know, you don't have that data in all, it's not easy to get elsewhere. But my question is, within your population, since you must have had data on socioeconomic status, like the level of education or Townsend Deprivation Index, were you able to control for those factors in your genetic analysis?
We did not control for those factors because we had those and everyone lived within an hour from the Marshfield Clinic. So it was the same across the board. So we looked at, so you raise a good point, that was not significant. So we'd like to, okay, so I didn't go into all that level of detail, but you raised a good point. We did not control for those factors because they were not significant.
Got it.
But that's what we'd like to do going forward.
Right.
And we certainly want to look at the Buffalo area and with Dr. Allison's help, what goes on here in Monroe County, because it's a very different population. And then look nationwide.
Yep.
No, those are exceedingly important.
Sure.
Yeah, this is very homogeneous, very homogeneous.
Well, it was really interesting looking at exons because we don't know a lot of exonal variants for glaucoma. So that wasn't really a problem, that you were really looking at the genes for glaucoma per se. But if you get a bigger sample size with this is going to be really interesting because you could do, is there shared genetic heritability across all chronic diseases? And, you know, then you can get replication in that way. So you need a bigger
Right.
sample size.
Oh, absolutely. What I was looking for too, even though we were getting, this was exonic, I was looking even to see if you all had, because you're the pioneer in the glaucoma genetics. If you had found any of these other genes where you had found common variants in them.
Right.
And any of ours hit that, but they didn't. We just found that Adam gene where they had an N of 3 and they showed the expression went up or down. And lamina curvosa cells, which was interesting.
Yeah.
But as you know, in genetics, there is, especially starting with the days of tetrarchia, you have these genes where one gene is responsible for deafness, blindness, and combined deafness, blindness, and a host of other things.
Right.
We find that with AMD too. So I was curious. If it's the same variant, then I'm gonna be like, okay, fine. That's why we had a clinical psychologist involved, PharmDs and everything for this. Because none of us is an expert in everything.
If we consider. So the polymorphisms in our genes describe our haplotype.
Mhm.
And our haplotype, and I believe everything's genetic. So let me just say that. Our haplotype is heritable features which are going to be inherited within our ethnic group, within our ethnic group. That's why people look like people of their same ethnic group. And therefore, that's likely in some cases related to geography, related to socioeconomic status, so on and so forth.
Mhm.
So how do you separate the fact that your haplotype is just a reflection of your place in the world, and however you want to describe that, and therefore your place in the world, whether it be anything from religious to all the things that make up who we are, that will tend to run in certain populations and also govern the behavior likewise. All of our behavior is reflective of our community.
Mhm.
Community we grow in. How do you separate out something that's genetic? Are we just looking at our haplotype and who we are and what community we come from? And then the implication of that could be a little bit ethically challenging in that we start to say, well, it's almost like eugenics, this group is the group that we're going to treat differently because they're more at risk, or this group is the group. And we're using genetics almost as a front for really what it is, which is our haplotype, which is who we are.
Mhm. So you bring up a good point, and that's why us and others have studied populations throughout the world, whether they're white from Utah, which is a completely different subset. And I have many populations from there, and which is the basis for the Ceph population that we measure against, that's up on the NCBI website, as opposed to, say, a white population from Boston, which is what we have. Those white populations are very different, and their variants, risk variants are very different, and their normal variants are very different. And we've published on this, but that's why you have to separate out with complex diseases, what is truly risk and what's just normal in that population. And I like to do that before I do any haplotype analysis. Because I don't know what Dr. Pasquale thinks, but I think a lot of the haplotype analysis that's done, I don't think we have the best methods out there. I think we do for Mendelian diseases, but for complex diseases, I don't think we have, this is my opinion, I don't think we have some of the best methods out there yet for calculating haplotype in complex disease. I think that's an ongoing development. And that's my opinion. You might have a different
I
opinion.
agree with you. I don't know if you control for principal component analysis.
Oh, God, yes.
So that at least gets somewhere toward answering that question. It
Mhm.
doesn't answer it completely, but
No.
you are controlling for the population structure when you go after looking for these axonal variants that you found for.
Right,
adherence.
but you have to be careful because some folks, and we like with Gonzalo Abacasis, who I think is one of the best statisticians of our generation, and Piero Heisey as well. I think there's still a debate whether do you control for age? Do you control for certain in sex if they're not significant? So if we can't even come to an agreement on that,
Right.
then how are we gonna come to an agreement on certain types of ethnicity? And that's why I think some of these populations, like the Marshfield or like my donor eyes just from Utah that are 1 hour outside of the Moran Eye Center, some of those have value. Or the population the Mayan population I recruited out of the Salama, Guatemala, or the Timor population, East Timor, some of those have great value in looking at normal variants and risk variants or protective variants. Some of like the Timor population gets no eye disease. The only thing they do is get aging cataracts, but if you remove their cataracts, there's no eye disease with age or anything. But they're also the thinnest population in the world with an average BMI of 19.8. Maybe that has everything to do with it. But what we call protective variants in other populations are through the roof. The percentage is like 60 percentile, where say in a white population it's 16%. How do you explain that?
And you're at the beginning of this project, so you need to do this across ancestries.
Correct, that's what we're trying to do.
And then you need to call back the people with the high genetic risk for non-adherence and prove they're non-adherent. Then
Right,
you answer his question.
right. But what I'm really interested in, those are who are protected. That's what
Right.
I'm interested
Right,
in.
right.
Okay,
Yeah.
okay,
Thank
so I'll
you very
leave it
much.
there. I don't want to go over.
That looks fabulous. Thank you.
Thank you.
We're gonna shift gears a little bit, go back into the clinical space here. And I think first up is Dr. Braun. So we'll have their resident case presentations and discussions with the audience coming up here. So Bill is one of our senior residents making his way through his cataract rotations, which he's enjoying very much. After graduating from Princeton with a degree in classics and later Yale School of Medicine, Dr. Braun came to FEI in 2020 and has been deeply engaged with the residency program through the years. In addition to clinical duties, he's been involved in community vision projects, revision of didactic curriculum, resident retreat organization, establishment of a mentorship program, and the pursuit of senior independent work on advanced anterior segment surgical techniques. He's grateful to his mentors, his colleagues in the program for being so dynamic and nimble in response to feedback. A generalist at heart, Bill intends to pursue comprehensive ophthalmology in New York City, currently interviewing at Mount Sinai. And this presentation could make or break you, Phil, today, but no pressure, okay? Welcome, Phil. No pressure.
All right, so I'm going to present a case of pseudoexfoliative glaucoma. So this is a 64-year-old Caucasian male who presented to our optometry service a couple of years ago, April 2022, for a routine eye exam. Medical history is as listed. His ophthalmologic history includes a melanoma in situ, was removed with Mohs surgery and a subsequent Hughes procedure by Dr. Gonzalez. Also had LASIK in both eyes. Sees pretty well. His pressure is a little high on the left, and we can see it's asymmetrical. That'll become a theme here with pachy's on the thin side, and then an asymmetric cup to disc ratio as well. He was labeled a glaucoma suspect at this visit due to the IOP and that cup to disc ratio. Had follow-up 1 month after this initial visit. Visual field was a little bit hard to interpret, wasn't very reliable first time tester. OCT we can see up here, a little bit thinner by average RNFL on the left, otherwise maybe some inferior changes. We'll see that varies a little bit in a future OCT. So and we can see the IOP is normal at this visit, but there's again that asymmetry favoring the left side. Decision was made at this visit to monitor with a repeat Humphrey at 6 months. at the 6-month visit, the Humphrey was actually okay, fairly reliable. Cleared for follow-up another 6 months with an OCT. And then just in May, had an asymmetric IOP with that left eye at 25. So elevated, and for the first time, it was remarked that there was some mild pseudoexfoliation on the lens capsule of both eyes. OCT is as shown, not a ton of new information, still maybe a little bit thinner reading on that average armicle thickness. And the patient was basically given the preference to treat with drops or with SLT and preferred SLT, so was referred to the glaucoma service. So saw glaucoma service a few months later in August. Normal pressures, but again asymmetric. Gonio was wide open, but heavy pigment noted in all 4 quadrants. Cup to disc ratio also asymmetric and rather cupped out in the left eye. That's probably not progression. That's probably just measurement difference from prior. And then right eye Humphrey was it's some non-specific defects, but left eye red is inferior arcuate defect. You can see I've displayed it up there. Decision was made to proceed with the SLT. Glaucoma has a lot of acronyms. So SLT stands for selective laser trabeculoplasty. And so what this is, a lot of lasers we use in ophthalmology are kind of coagulative or ablative and destroy tissue. The idea here actually is it's a stimulative mechanism. So you have low energy, broad beam across the trabecular meshwork. And that distributed energy is thought to work by recruiting macrophages, upregulating interleukins, and ultimately facilitating TM outflow. It's thought to be especially effective in pseudoexfoliative glaucoma because of the pigment deposition and subsequent light absorption. So I've threw up a video here. This is not a pseudoexfoliative case, but just for those of you who maybe haven't seen this or in our research, you can see basically the lasers is aimed over the trabecular network, and you can see what are called champagne bubbles. Those are what are floating up kind of into the AC. And often you'll titrate so that you get a good response with those bubbles, usually between 0.3 and 1 millijoule of power. So got the SLT treatment in that left eye, good response at the 1 week follow-up. Sometimes it can take longer, certainly, to respond. And then just this month, IOP still normal, but asymmetric again. And as of the last visit, decision was made to follow up in 6 weeks for reevaluation, and if the left eye pressure was greater than 17 to start drops. So this is a pretty typical presentation of pseudoexfoliation syndrome. It's also called exfoliation syndrome. There is a true exfoliation syndrome, but it's very, very rare and associated with glass blowing, hence the glass blower up here. And the idea is that there's actually thermal infrared radiation that can cause the lens capsule to exfoliate. In pseudoexfoliation syndrome, the material that accumulates just looks like that, hence the name. I like languages, so we have to have a little etymology there. What it is actually is this fibrillar material that's deposited throughout the anterior segment. We'll see some pictures in a moment. It's the most common cause of secondary open-angle glaucoma. It often presents asymmetrically or unilaterally and is associated with older age. It's also a systemic condition. It's been found in skin, lungs, heart, and liver. To date, the most significant effects have been found in the eye. And it's believed to be secondary to basement membrane and extracellular matrix dysfunction. So here's some pretty textbook pictures we have on the right here, that pseudoexfoliative material on the lens. Sometimes you'll see also like a central area of that material and a mid-peripheral clearing where the iris basically is rubbing it off. So it's a bullseye pattern. On the top left, you see exfoliated material on the iris margin there. You can have iris atrophy and infiltration in the vessels, for instance, of the iris. And then in the bottom right, we have a histological image of that material on the lens capsule. Cataract surgeons know it or should know it well. It's often dreaded when you come across it in clinic because particularly because of the weak zonules that it induces, which can lead to phacodenesis in the most extreme case. So this is a video by Dr. Alward at Iowa, really nice example. If you look right in the center of the at the pupil relative to the margin, you can see the lens jiggling around. So that's some phacodenesis there. You can also have, because again, those zonules are weak, some changes in AC depth or dilation as mentioned in the prior slide, and then capsular changes could make the bag prone to break and rupture. This is a really cool picture here, not cool for the patient, but a cool picture of a sublux lens in the setting of pseudoexfoliation. You can see the material on the lens, but you can also see it on the zonules, all these fluffy things on the zonules is the exfoliative material. So let's talk about pseudoexfoliation glaucoma. So not everybody with pseudoexfoliation has glaucoma. Up to 50% of people end up developing it. There is an association, like probably for or OCAPS is the Scandinavian Association. We're going to dive a little bit more into that later. It can have a higher IOP and diurnal fluctuation versus primary open angle glaucoma, and it may be more aggressive. And then the angle usually has heavy pigmentation and can have a Sampolese line. So this is another Dr. Alward video, and you can see that the very top line of pigment that's kind of irregular anterior to Walby's line is characteristic. It's not pathognomonic, but you can see that in pseudoexfoliation glaucoma. So to get a little bit deeper into the mechanism, how this causes glaucoma, it's really at least a twofold mechanism from what we know. So this fibrillar material is synthesized in cells in the anterior segment, and then as the AC drains, it gets kind of lodged and mechanically blocks both uvascleral and conventional outflow. But there's also a thought that these optic nerves may be particularly at risk because of the effects of fibrillar and elastin changes on the lamina cribrosa itself. We talked a little bit about why SLT is effective in these cases. Otherwise, you're doing your typical opening angle glaucoma treatment, drops, and then surgery if it comes to that. There is a possible secondary mechanism here, which is angle closure, and that's again because you have those springy zonules, you can actually have the lens move forward and close the angles. Kind of pearl here is that you want to use dilating agents as opposed to meiotic agents, because that's going to move the complex backwards and away from the iris. Recommended at least annual monitoring, even in those who don't have glaucoma but do have the syndrome. So we talk a lot more about genetics here, I think, since Dr. Levin came. So I think that's a great step forward. But it's also kind of fun to think about, he's always saying, oh, it's more complex than genotype phenotype, right? There's a lot that happens between the genotype and how we get to the phenotype. And so pseudoexfoliation syndrome is actually a good paradigm of this. And so a lot of the next couple of slides actually draw on Dr. Pasquale's work. So I appreciate that. And we'll give him a chance to kind of open things up at the end here. But in 2007, there was an Icelandic GWAS that identified 3 single nucleotide polymorphisms of gene LOXL1, have a strong association with pseudoexfoliation syndrome. LOXL1 is thought to be, it's an enzyme that's important for collagen and elastin metabolism. So this is kind of checking out from a physiologic perspective. There have been some others that have been identified more recently. And it's this necessary but not sufficient, or nearly necessary but not sufficient paradigm. So 90% of people who have pseudoexfoliation syndrome have these variants, but 80% of people who have the variants do not have pseudoexfoliation syndrome. And this opens up a whole role for environmental interaction, epigenetics, and the like. So let's revisit that Scandinavian Association. So the sort of surface reading is always, there's a genetic association with Scandinavians. And indeed 50% of open-angle glaucoma is associated with pseudoexfoliation syndrome in Scandinavian countries. But if you look at Americans of Scandinavian descent, they actually haven't found this association. Sort of complicating the picture. Similar complexity introduced when we're looking at different ethnic and racial groups. So there tends to be variety within these groups. So you know, the surface reading is that among those of African descent, particularly in Africa, there's almost no pseudoexfoliation syndrome. But actually, if you look at those of African descent in South Africa, it accounts for about 20% of glaucoma, according to some research. So they've even found among married couples that there's concordance in pseudoexfoliation syndrome, suggesting some kind of environmental factor at play. So environmental factors that have been sort of discussed, investigated in the literature include latitude. There's at least a couple interesting studies about looking within the United States and looking at people who have been in different regions for their entire life. And so like if you look at the South, kind of the middle part of the country and the North, there tends to be an association with increasing latitude. That kind of jives with what we know about the Scandinavian countries. Sunlight, UV exposure, maybe that has initiates a cascade or causes damage, free radical release that has a part in the disease process. Climate, there's actually been some work done on coffee. I think it was a Scandinavian study about people who did not drink coffee and then people who drank more than 3 cups a day. And there was a significant association with those who were heavy coffee drinkers, with a proposed mechanism there being maybe coffee is associated with elevated homocysteine levels, which perhaps disinhibits matrix metalloproteinase and you can see how that can impact basement membranes like extracellular matrices, and then low folate intake. So that's just a quick overview, but I wanted to open the floor to Dr. Pasquale here. And I don't know if we have time for all these questions, but you can take your pick. So just quickly, that was a very quick overview, but if there's if there's something later, something kind of updates, something on the horizon, that would be interesting to hear about, that'd be great. A lot of the literature, second question I read focused on the syndrome, but maybe not as much on the glaucoma. And I was curious as to whether genetic study, there's enough genetic studies out there to say interesting things about the glaucoma, specifically within pseudoexfoliation. What's the ultimate goal of understanding, in this case, the genetic environmental interaction? If it's therapeutics, what might that look like? And then I think Eileen's actually talking a little bit about AI and research, so we'll hold on that one. But have at what you like.
Thank you. What a wonderful presentation. So much to unpack there. Let's focus on the genetics. Okay, so if you heard Meg say, so you found all these genes, how much of those genes explain the disease? So we did that calculation. It's 2%, very small amount. And there have been adequately sized GWAS studies of exfoliation syndrome. And I don't use pseudoexfoliation, so I'm talking about the same thing. So there have been adequately sized GWAS done. We've only got 7 hits for exfoliation. And I'll show you in my talk, we've got 302 for primary open-angle glaucoma. So this is not a polygenic disease. And there really isn't any role for genetics in helping to identify patients, because 80% of people in this room have that loxone 1 SNP. Right. You mentioned that this patient had Mohs surgery at the beginning for a basal cell carcinoma, I believe?
Melanoma in situ.
Yeah. So we have shown melanoma in situ. We've shown a couple of different times, a couple of different ways, that basal cell carcinoma in the head and neck region and squamous cell carcinoma in the head and neck region is a risk factor for this condition, implicating ocular UV exposure. It is really hard for people to wrap their head around this, because it's true, the latitude effect, that doesn't make sense. There should be more UV exposure at the equator. However, what people don't take into account is we're not solar gazers. And so we're talking about sun bouncing off the ground into the eye. At the equator, the sun comes in parallel. There aren't a lot of opportunities for the sun to bounce off the ground into the eye. But the further away you get, because the Earth rotates 23 degrees away from the normal, and the different times of year, there's more time, more possibilities for the sun to bounce off snow and or water into the eye. And that's what we think is going on. And the only way we're going to prove it is by making an animal model of it. And so we're going to brainstorm about this in the new year with Audrey Bernstein and some folks at Mount Sinai to try to come up with a way to mimic ocular UV exposure in the way we think it happens to these patients, to see if we could reproduce this phenomenon. There are no Mendelian variants for exfoliation syndrome, and there are no animal models for it. So that's where we have to go. Yeah, it's one on a clinical note. You indicated in the beginning that the pressure was 13 in the right and 20 in the left, and I think patient had exfoliation at that time. Did you say the patient had exfoliation then, or
I
wasn't
think
sure?
they were diagnosed like 1 or 2 visits in. Yeah.
So, but we could pretty much assume that he did.
Yeah.
And so if you could do the math, that means that the outflow facility in that eye with the pressure of 20 was 2 to 3-fold less than it was in the fellow eye. That means that eye is at risk for glaucoma and could benefit from treatment. And so even if the field is unreliable and the OCT says that the nerve's not damaged, I start treatment on those patients at that point, because I want to equalize, I want to get the pressure to the other eye. The other eye is telling me where God told them that pressure should be. Okay, so that's where I want to try to go. And so that's what that would be my approach. SLT is fine, but the pressure went back up again, right? It went back up to 18. So more work needs to be done to get that pressure down into the low teens. And now the patient's got exfoliation in both eyes, and the pressure in the right eye back up is up to 18. That's probably not good for that eye either. Yeah. But great presentation. This is a fascinating.
Yeah. It's fascinating work.
Excellent. Thanks, Bill. Eileen, are you? So next up is Dr. Eileen Mayrow. She's in her 2nd year in FEI residency program. She's a Philadelphia native and entered medical school at Jefferson Medical College, focused on becoming an ophthalmologist, and her passion for vision care hasn't wavered. While in medical school, she published while working in research labs at Wills and the NEI, and she's already published or contributed to over 25 peer-reviewed manuscripts, ranging on topics from population-based health to ocular oncology. She recently presented some fascinating work on 3D heads-up cataract surgery at her annual Research Day presentations in June. And Eileen feels fortunate to be part of the close-knit community at FEI and to have the opportunity to learn from her attendees and co-residents. We're excited to have Eileen and look forward to great things she's going to accomplish. Outside of FEI, and Eileen enjoys meditation, jogging, and reading short stories. Welcome, Eileen.
Thanks. Okay, so for glaucoma rounds, I am presenting a case of a 61-year-old female with past ocular history of open angle glaucoma of both eyes, who is presenting for her 6-month glaucoma follow-up. She denies any visual complaints, and her only ocular medication is travoprost nightly in both eyes. Her visual acuity is 20/30 OU, IOP by applanation is 13 OD and 15 OS. PACIs are low normal at 529 and 516, and her gonio is grade 4 by Schaefer. In terms of her exam, she has MGD in both eyes, some dense inferior PEEs, and the start of a cataract with 1+ NSOU, as well as 1+ cortical spoking in the right. She has vertical elongation of both of her optic discs, and her cup to disc is 0.6 in the right and 0.7 in the left. She also has a chirpy temporally on her peripheral retina exam. So moving on to her visual fields. So these are both visual fields of the right eye. The image on the left on your left is her visual field from 1 year ago. The one on the right is her visual field from today. They're both SITA standard, and we can tell that there are minimal fixation losses on both, and they're good quality studies. First of all, you can tell from the total deviation that there's a global depression, possibly related to her developing cataract. In terms of her pattern deviation, she appears to have a superior nasal step, a superior nasal step and superior paracentral defect a year ago versus the on the image on the right from today. You can see that there's possible progression of her superior nasal step and possible progression of her superior paracentral defect. In addition, you see that there are a few points on her pattern deviation from her visual field today that weren't there previously, and it suggests a possible new inferior paracentral defect. And so I'm going to put the mean deviation aside because of the global depression, but her pattern standard deviation is 4.63 a year ago and 5.13 today. I think, assuming that you're ignoring the grayscale, I think is a little bit deceiving for what's happening in this case, and you're looking at the pattern deviation. There does appear to be some progression, but I would argue it's subtle. And in the other eye, I would argue whether there's progression is even more equivocal. So this is the left eye, 24-2, SITA standard, minimal fixation losses. Again, global depression on the total deviation. And in terms of the pattern deviation for this eye, you can see that there is a superior nasal step and a superior paracentral defect on her image on your left. Versus today, to my eyes, that superior nasal step appears unchanged. The superior paracentral defect actually appears a little bit less dense on the pattern deviation, but there is a suggestion of a new superior rim defect. Again, going to the pattern standard deviation, it was 6.93 a year ago, 6.46 today. And I think it's sort of unclear whether there is progression and which components of the visual field are stable versus which have shown progression. And that's why I'm going to move on to visual field assessment. So as you just saw, visual field defects have traditionally been classified using qualitative descriptors as well as semi-quantitative summary indices. These indices reflect visual field loss severity, focality, and probability of glaucomatous etiologies. And common summary indices include things like mean deviation and pattern standard deviation. And while the above measures offer important insights into a patient's glaucoma, they can be subjective and lack clinical standardization. So in the ocular hypertension study, Keltner et al. Offered a visual field classification system based on manual inspection of fields. Common patterns, as you can see here, include altitudinal, arcuate, partial arcuate, paracentral, nasal step, and temporal wedge defects. However, it's critical to note that this study did not quantify these patterns. Again, they're qualitative descriptors of what was seen. And ideally, a system that is a unified quantitative visual field classification system is what we would need in order to standardize visual field assessment. This system ideally would be automated, rapid, and reproducible. It would classify information about the qualitative pattern and quantitative severity of visual field loss. And finally, it could be used to decompose complex visual fields like the one I had shown you into multiple components that can each be tracked over time. And this need is how archetypal analysis was born. It quantitatively classifies patterns of visual field loss without the potential bias of clinical experience. It uses unsupervised machine learning. Machine learning describes the ability of a machine to learn something without needing to be explicitly programmed. And in unsupervised machine learning, models are given unlabeled data, and they're allowed to discover what patterns exist within the data without any explicit guidance or instruction. Elsie et al. Conducted a study in which 13,321 Humphrey visual fields were subjected to unsupervised learning to identify archetypes or prototypical patterns of visual loss. 17 glaucomatous vision loss prototypes were identified, 16 of which closely corresponded to clinically observed visual field patterns. And as you can see, the ocular hypertension study classifiers are among the prototypes identified. And this image here is an example of how a patient's visual field is decomposed by archetypal analysis. The visual field shown depicts an inferior arcuate defect that is decomposed quantitatively into an inferior nasal defect, an inferior altitudinal loss, and an inferior paracentral defect. Shared clinical features between computationally derived visual field archetypes and clinically observed visual field patterns support the clinical validity of archetypal analysis. It may help to identify patients at higher risk for developing particular types of visual field loss that could impact their daily activity and quality of living, such as central and paracentral losses. And additionally, archetypal analysis can help track visual field progression. So this is an example of a clear visual field progression. It shows a superior altitudinal defect, and it shows the consensus of progression based on conventional algorithms, the clinical reference standard, and archetypal analysis. As opposed to this, which is a more subtle visual field progression, it's a superior nasal step. And the archetype method seemed to detect this visual field progression when conventional algorithms did not. There have also been applications of archetypal analysis to non-glaucomatous optic nerve diseases. So in 3 distinct studies, visual fields from the optic nerve treatment trial, the idiopathic intracranial hypertension trial, and an outpatient neuro-ophthalmology clinic identified and quantified patterns of visual field loss. And this represented an objective method of measuring and monitoring disease-specific visual field defects. I wanted to thank Dr. Allison for her guidance with this presentation and Dr. Pasquale for actually introducing me to this topic and research we did a few years ago. These are my references and these are my discussion questions.
So, thank you, Eileen. This is a great presentation. Let's make it related to your patient, right? We wish we could have done the archetype analysis on that,
I know,
on
if
that
only.
patient, but send us the data, we can do it for you.
Oh,
So
that would be
we'll be happy to do it. The R script for doing it is widely available. It's not hard to do if you want to. You're a very capable person in IT. You could try it, see how it goes, and if you're not getting anywhere, we can help you out with that. Because I worry about that patient. I'm worried that
As do I.
because there are hints there that that's a fast progressor.
Mhm.
And everything aside, the patients that get this early paracentral loss, to me, they tend to be the fast progressors.
Mhm.
And this is happening at pressures of 13, 14. And I don't want to derail the conversation about using artificial intelligence for this, but like what I'm doing now for these patients is there's this service called My Eyes. They'll rent them an eye care home dynamometer for $250. They could use it for a week. And I've been telling these kinds of patients to check their pressure at home at like 5 o'clock in the morning, 6 o'clock in the morning, and I've been shocked. Pressures 25 up to 30. I've seen some 40s pressures at that particular hour. And so we don't know if this is something everybody's happening to, but certainly we're paying more attention to that kind of stuff. It's really important. We applied the archetype analysis to a incident primary open angle glaucoma data set in Nurses Health Study, Health Professional Follow-up Study. So we got like 2,000 primary open angle glaucoma patients as they were being diagnosed everywhere in the United States. And we applied archetype analysis and we found all the same patterns that Tobias Ellis found. And what was really interesting was that some patients had a high component of that advanced visual field archetype. And it turned out that even though only 1% of our population was of African descent, African ancestry was the risk factor for having that advanced archetype. And so it's really interesting what these bioinformatic approaches are teaching us about glaucoma and giving us insight into the disease. And ultimately what we want to do is see if these different archetypes have different genetic signatures. Like patients who present with paracentral visual loss, maybe they have a different genetic profile,
Yeah.
like what Meg is showing you. You can find a genotype profile for just about anything if you put your mind to it, compared to a nasal step, that there's a different profile for that. So that's what we'd like to ultimately do.
Yeah.
But thank you for your presentation.
I just wanted to mention something
Yeah.
also, and one of the things I noticed is patients of African ancestry, they tend to have more of a central loss earlier than typical. Yeah, so they progress really rapidly.
Yeah, we saw that in the nurses' health study. Even with only 1% of people being of African descent. It's incredible. Yeah.
Thank you all.
Thanks, Alan. We have one more resident presentation today. Dr. Ozimba. Kayla Ozimba began her first year of residency at Flaum after completing her internal medicine internship here. Oh, yeah. We good? Okay. She comes to Rochester from Phoenix City, Alabama. And Kayla studied chemical engineering at Howard University, where she graduated magna cum laude. She then attended medical school at the University of Alabama. Roll Tide.
Roll Tide.
Kayla said that she really enjoys the supportive environment of faculty, co-residents, and staff at FEI. She's already been very involved in FEI's outreach work, including school vision screen and FEI's health equity efforts. And she just got married last week, so congratulations.
So our objectives today are to review known genetic genes, to review potential novel genetic glaucoma risk factors, and to understand the racial disparities in glaucoma research. So our case begins with a 58-year-old female. This is a Black female with a chief complaint of cloudy vision in both eyes. Her review of systems was positive for light sensitivity, blurriness, and floaters, and negative for eye pain, discharge, redness, and flashes of light. She had a family history of glaucoma, both in father and her brother, and a visual acuity that was normal at 20/20 OU. Her pupils were equal round and reactive, and her pressure was 42 after several tonometry readings. Her pachymetry that day was 533 and 559, and the rest of her exam was relatively normal, but did have a cup to disc ratio of 0.4. She was treated with Lumigan nightly and placed on Timolol BID. We got a baseline visual field test, which was reliable and overall relatively normal here, which was important. Our baseline OCT RNFL also showed average nerve fiber layer thickness and relatively good symmetry between the two optic discs. At her follow-up, her initial follow-up was a week later with her pressures. Her IOP was 13 on both the Lumigan and the Timolol. She was transitioned to latanoprost nightly and placed on Timolol once daily. At 6 months, she came back in, visual acuity was stable, pressure again was normal at 14 and 13, and tapered down off of the Timolol, and she continued on latanoprost nightly. At 1 year, as we know, so much with, unfortunately with glaucoma patients, her pressure was now 24, and she endorsed medication non-adherence. Her chief complaint with the medication was eye irritation, difficulty with keeping up with the schedule of a nightly drop. And so SLT was recommended for IOP control. And that's where we are with the patient so far. So at that visit, which was just a few months ago, OCT RNFL was done a year later. And here she shows just a little bit of progressive thinning and a little bit of RNFL, more asymmetry with this OCT RNFL. And so I wanted to talk about the basics of genetics and glaucoma with this patient who has a strong family history and a risk of progression, disease progression. So genetic discoveries in glaucoma date back to a German ophthalmologist who who first reported multi-generational families with glaucoma in 1869. Recent and larger studies have estimated that POAG, or primary open-angle glaucoma, heritability is more than 70%. It's estimated that 5% of cases that are caused primarily by this are seen in the MYOC, Optin, and TBK1 genes. A mutation in these three genes are usually passed through autosomal dominant inheritance. But even with knowing that, 95% of these cases are thought to be caused by combined factors, such as genetic and possibly environmental and risk factors. Another clue that glaucoma is spread mostly, or not mostly, but the genetics play a huge role with glaucoma is how we've mentioned so many times before today, that we see such a difference in prevalence between different races and ethnicities. So MYOC was the first gene to be associated with glaucoma. It was discovered in 1997. It's a mutation that's found, it's a gene that we found over hundreds of mutations in this gene. Some of them associated with juvenile open-angle glaucoma, others associated with primary open-angle glaucoma. Most of these mutations are associated with high intraocular pressure. There's several novel genes that are being studied. Majority of these genes are associated, but have not been found to be significant as of yet. And so ataxin N2 is a calcium homeostasis gene that plays a role in calcium homeostasis, and it also is found in the cytoskeleton organization. CDH6 is expressed in ciliary muscles and is a connection to Alzheimer's and medication noncompliance. FOXC2 is seen in the Schlemm canal and trabecular meshwork development, and LDLR are seen in cholesterol dysregulation. All of the genes currently that we're studying kind of converge on four areas in the pathogenesis of glaucoma: lipid abnormalities, extracellular remodeling, neuroprotective or neurodegenerative, and eye development. So lipid abnormalities, dysregulation of lipids is seen often associated with glaucoma. The trabecular meshwork remodeling is seen in glaucoma as well, and often a lot of glaucomatous eyes have stiffer trabecular meshworks. As we saw earlier in our talk, CHD6 is a gene that's currently being studied to be seen to have some type of neuroprotective, potentially neurodegenerative role, as it's seen in Alzheimer's disease. And mutation in this gene is seen in Alzheimer's disease and also medication noncompliance. Medication noncompliance, we know, is a huge problem with our glaucoma patients. At 1 year, upwards of 70% of these patients are not using their drops. And regardless if it's eye irritation, like our patient talked about, or difficulty with schedules, it's a huge burden and a huge risk factor for progression in disease. And so research studies that these non-adherence, the heritable genetic component could be upwards of 40%. This gene, this mitochondrial gene that's seen in the pathogenesis of Alzheimer's disease, now is potentially suspected to play a role in medication noncompliance. And then racial disparities. While we perform all of this research in glaucoma, it's important to note that glaucoma is highly prevalent in African descendants and Latin descendants. Yet majority of the research that's being completed at this moment does not necessarily include that high-risk population. I think this is in part by where we're getting our data. And so the biobanks that we use, the largest biobanks for genetic research is the UK Biobank, that's just largely made up of Caucasian individuals. And so the research, while it's good research, is not able to be applicable to these high-risk patients with family histories and, again, of African and Latin descents. So my questions today are, in clinical practice, we can't get our genome studies on all of our patients. And so how do we identify these at-risk patients? How do we aggressively treat patients with a family history of glaucoma? And how do we as physicians and physician scientists address the lack of genetic research in minority patient populations, particularly African-American and Latinx populations? And what role does genetic research play for the early detection of glaucoma?
Thank you.
Well, my talk's gonna cover a lot of the answers to your questions. Let me tell you this, one of the things, the poor man's approach to this is to question number 2, which is so important, is how do we find these people? And if I see a young African-American patient in the 40s, or somebody's got a pressure in the 40s, and I wanna see all your kids. I don't care how old they are. I have an 11-year-old who presented with pressures in the high 30s, 0.9 cups in both eyes, and she had no anterior segment dysgenesis. It looked like primary open-angle glaucoma, and there seems to be no age cutoff. I mean, people are gonna have to wrap their head around this, that this is not a disease of elderly people to begin with, even in Caucasians. It's a disease that happens in the 50s and 60s. And in the African-derived population, it's happened 1 or 2 decades earlier. And there's other data to show that too. Richard Lee went down to Little Haiti, south of Miami, and looked at 1,000 Afro-Caribbean patients. And 20% of them in the age 20 to 40-year-old group had pressures greater than 24 and or a cup disc ratio greater than 0.7. It's happening earlier. And that's where we got to find it to prevent glaucoma blindness in this population.
Okay, thank you.
I'll talk about biobanks that are more representative.
Looking forward to that.
Okay.
All right, why don't we take a 5-minute break, get a stretch, bathroom break, etc., and then we'll come back for the feature lecture. Everybody for settling down so quickly. I just worked by out there. We'll get started. Okay, please welcome Lou Pasquale, who's the site chair of the Department of Ophthalmology, Mount Sinai Hospital, the Shelley and Stephen Professor of Ophthalmology, Deputy Chair for Ophthalmology Research, Director of Mount Sinai Hospital, New York Eye and Ear Eye and Vision Research Institute, in the Department of Ophthalmology at the Icahn School of Medicine at Mount Sinai, and apparently still finds time for research. That's a lot of administrative stuff, believe me. Dr. Pasquale is a physician scientist interested in the pathogenesis of primary angle open glaucoma. He serves on the editorial board of Ophthalmology Glaucoma, International Glaucoma Review, and American Journal of Ophthalmology. He was a member of the National Institute of Health's National Advisory Eye Council, Vice President of ARVO, and President of the New York Glaucoma Society. He's a member of the American Ophthalmological Society and Glaucoma Research Society. He's published extensively and given numerous named lectures, as well as keynote presentations throughout the world. He is an NIH principal investigator with continuous support since 2006. His research focuses on understanding the complex genotype-phenotype correlations operative in primary open-angle glaucoma. His work has highlighted environmental risk factors for exfoliation syndrome, the most common form of secondary open-angle glaucoma, and the role nitric oxide signaling plays in the pathogenesis of primary open-angle glaucoma. He is regarded as one of the top 10 researchers worldwide with an H-index of over 77 and over 26,000 citations of his work. It's certainly our pleasure to welcome a world's expert visiting professor to the Flaum Eye Institute. He'll be presenting on glaucoma genetics update.
While I get my slides up there, it's been a lot of fun. We've got a great department here. It's so nice how compact everything is. And Dr. Allison cornered me in Rome during World Glaucoma Congress, and I said I was delighted to come, and it really has proven to be the case. Certainly, all all of the talks that you heard serve as a nice foundation for what I'm going to talk about today. And as I said, I'm going to answer some of the questions that were raised earlier that are really important. But keep in mind that the work I'm showing you is still a work in progress. Here are my financial disclosures. Without the support from NEI, and I understand Michael Chang's going to be here for your annual meeting in June, I would be nowhere. Really, that has made my career. And I've been able now to attract support from the Glaucoma Foundation in New York and Research to Prevent Blindness. And so that has also helped to bolster the work. So I could work with students so we could explore side hypotheses that are also important in the disease process. My consultations are really not relevant to this talk. What are we going to do? We're going to talk about glaucoma genetics overview. Some of this has already been nicely presented in the prior talk. We're going to talk about common genetic polymorphisms. You heard Meg talk about exonic or coding variants. Most of the variants that we find for glaucoma are in non-coding regions. We don't even know what they do, but we know they're important, and I'm going to show you why. The clinical picture of glaucoma as we're discovering it by doing a screening by genetic risk score is different than your perception of what glaucoma is, and I'm going to show you an example of that. And the last question is going to be, after you hear all of this, you're going to say, how am I going to find my genetic risk score for glaucoma? And we're going to talk about that too. So this is a disease, familial hypercholesterolemia. We would call this a Mendelian disease. There's one gene defect in an LDL cholesterol receptor, and there's one problem, an inability to remove LDL from the blood. This causes a lot of systemic manifestations, some of them around the eye, cholesterol buildup around the lids, cholesterol buildup in the cornea. But the big problem, of course, is cholesterol buildup in the coronary arteries that can lead to premature myocardial infarction and death. We have a disease like this in glaucoma. You heard in the last talk, it's called myocilin glaucoma. Myocilin's a small gene. There's 3 exons. Most of the pathological mutations in myocilin are in the 3rd exon. So this is a gain of function mutation. And what happens is because of these gain of function mutations, the myocilin protein becomes misfolded. This translates into alterations in trabecular meshwork cell size and shape that cause a reduction in the outflow facility. Now, but when we take a step back and say, what's this got to do with primary open-angle glaucoma? The prevalence of primary open-angle glaucoma in people over the age of 40 is about 4%. Guess how many of those people have a myocilin mutation? Only about 4%. And of those with the mutation, only 25% will get glaucoma. So when I got to Mount Sinai, we used our biobank to call in all the people that had a myocilin mutation to say, who are these people and what do they have? Well, it was during the pandemic. There was only 25 people out of 50,000 who had this mutation. 3 of them showed up. 1 of them had glaucoma. Okay, so myocilin mutations account for very little primary open-angle glaucoma. Yet we hear again and again, genetics has got all to do with this disease. So what's the source of the missing heritability for primary open-angle glaucoma? And this is really important because this is a public health problem. It's estimated that 54 million people around the world have primary open-angle glaucoma, and there are no places that are immune to this problem. But it's particularly hyperendemic in the Afro-Caribbean population. And so if you go to St. Lucia, about 8% of people have primary open-angle glaucoma. So we need to figure out what are the genes. So I just explained to you what a Mendelian disease is. You have one gene, it's uncommon, but it has a fairly high penetrance, but it doesn't explain a lot. Let's say it doesn't explain all of hypercholesterolemia, and myocilin clearly doesn't explain all of primary open-angle glaucoma. But for common complex disease, the hypothesis is that many common variants gang up on one another to contribute and tip the patient over from normal to glaucomatous optic neuropathy, and they contribute to the disease in complex ways. So how do we find these common complex polymorphisms? And really, when you think about it, so the mycilin gene that we just heard about, that was discovered in 1997. So that was discovered by looking at families and taking big, large families, getting their DNA and just meticulously going through chromosome after chromosome to find out where was the heritability being transmitted from one generation to the next. That is pretty tedious way of doing it. And in 1997, we did not have the blueprint for the human genome. In the year 2000, that was when we actually had the blueprint for the human genome. Here you see a picture of Bill Clinton and Francis Collins, who was then the director of the NIH, announcing, hey guys, we've got it. We've got the blueprint from the human genome. We know what all the A, T, C's, and G's are, starting from chromosome 1, going all the way to the X chromosome. This sent us off to the races because we could genotype a lot of people and we could see how these common polymorphisms were associating with a common complex disease. And so that's what we did. In 2012, we started this out and it was a monumental effort. We got together over 3,000 primary open-angle glaucoma cases from unrelated people and 3,000 from controls. And we found one polymorphism. So well, this is going to be a lot of work. So this is called a Manhattan plot. And what you have on the x-axis are all the chromosomes starting from 1 to the sex chromosomes. Glaucoma. $2 gets you on the bus in New York City. It isn't going to solve the problem of figuring out how much genetics is playing a role in this disease. So we kept increasing the sample sizes. 2014, doubled the sample size, and some genes are starting to pop up. So now all these things here in blue and you know, like also TMCO1, CAV1, these genes are popping up as being related to primary open-angle glaucoma. We kept going. 2020, increased the sample size to nearly 8,000. And now we have over 100 common polymorphisms associated with primary open-angle glaucoma. 2023, increased the sample size even further and include information, genetic information about intraocular pressure and cup disc ratio. And we have over 300 common polymorphisms associated with primary open-angle glaucoma. Looks like a lot of alphabet soup. What am I going to do with this information? So what people are doing with this information is just adding them all up. So everybody in this room probably has at least 25 of these genes that I'm showing here that are associated with primary open-angle glaucoma. Not everyone here is going to get glaucoma. But the idea is that if we add them up, there's going to be a cutoff where it's going to cause glaucoma to develop. So it's this analogy of like, I have a couple of, think of these common polymorphisms as pennies in your pocket. If you just got a few of them, you don't even notice them. But if you got 50 of them, your pants start to feel heavy. And if you have 100 of them, your pants fall down. And that's when you get glaucoma. So that's the idea. That's the idea. And it works. And I'll show you why it works. So this was a study done in Australian cohort. They had a large cohort of patients with advanced primary open-angle glaucoma. They genotyped all of them and they genotyped some controls and they added up the common polymorphisms. And basically what you have here on the x-axis are deciles of genetic risk score, how many pennies they had in their pocket. So, and here's the odds of having advanced glaucoma. So people with the highest decile of genetic risk score had a 15-fold increased risk of having glaucoma. So that is saying that collectively, if you have a critical number of common polymorphisms, it's behaving like mycilin. Now we're getting somewhere in terms of understanding what's going on with this disease. So what other clinical utility has been shown? And this is all published stuff. This isn't new information at this point. It's like 2 or 3 years old at this point. Patients with a higher polygenetic risk score are having an earlier age of diagnosis. And so here again are deciles of genetic risk score, and this is mean age at diagnosis. People in the lowest decile of genetic risk score, yeah, some of them were getting glaucoma. It's a complex disease at around age 62.6. But those with the highest decile, they were getting the disease at age 56. So about a 7-year difference. And so again, indicating the utility of a polygenetic risk score. Here's another study. Patients in the top 5% of polygenetic risk score versus those in the bottom 95% were more likely to have visual field progression despite treatment. So again, this is suggesting that a high genetic risk score even causes some resistance to conventional treatment for the disease. Here's another study done with home tonometry. They took 176 patients, they genotyped them, they created a genetic risk score for predisposition to having a high intraocular pressure. Those with the highest genetic predisposition to having a high eye pressure were more likely to have eye pressure spikes early in the morning. They had higher eye pressure levels than those with lower genetic risk scores. Question?
Are all loci equally weighted? The genetic risk score?
Not quite. But you don't have to weight them because they don't have high weights. The highest weight you'll see is for TMCO1, which is like 0.4 or something like that. You know, these odds, you're talking about odds ratios on the order of between 1.1 and 1.5. This is not big. So like if you were to say, what's the odds ratio for a mycelium mutation? It's more like 15. That's why you got to add them all up. But we've weighted them. It doesn't matter though, because they're all low weights. And if you have questions, please shout them out. So what have I said so far? The polygenetic risk score has clinical utility. Patients with the highest decile of glaucoma PRS present with glaucoma 7 years earlier than those with the lowest PRS. That's exciting. Early POAG patients with the highest risk score were more likely to have visual field progression. So that case that Eileen presented, we don't know what that patient's genetic risk score is, but maybe that's a patient with a high genetic risk score, and that's why that patient looks like they're in trouble with early paracentral visual field loss. We don't know. Patients with the highest IOP PRS had early AM IOP spikes or higher IOP by 4.3 millimeters of mercury higher than those with the lowest genetic risk score. So now these studies that I've just presented to you have taken patients that had known glaucoma status. They were either defined as normal or abnormal, and that's how all this discovery has been developed. But what if we created the risk score and we applied it to a totally naive population? Does the scoring help to identify patients by disease status? And so that's what I'm going to show you now. So what we're doing is we have an NIH grant, and we're using two data banks, two biobanks, one at Mount Sinai and one at Mass General Brigham in Boston, working in collaboration with Janie Wiggs and her group up there. The Mount Sinai biobank is probably one of the most diverse biobanks in the world because it's representative of New York City. It's 30% African Americans, 30% Hispanics, 30% European-derived Caucasians, and 10% everything else, which is mostly Asian, but really mixed group of populations. So in the biobanks collectively, there's about 90,000 participants between New York and Boston. So we took all of those genes and we applied something called lasso sum to calculate their genetic risk score based upon the genes that we have, and literally 114,000 loci throughout the human genome are contributing to the genetic risk score for primary open-angle glaucoma. And so you see in a bell curve here, these are the people with low genetic predisposition. These are the people with high genetic predisposition. And, you know, the question is, if we call in these people with the low genetic predisposition and we call in these people with the high genetic predisposition, what are we going to find? And so that's what we did. And so at ARVO, we're going to provide an interim report. The plan is to go to 800 patients. Right now, we only have data on 201 participants. You see the mean age, and we have a genetically inferred ancestry. And this is the genetic ancestry of the patients we've evaluated so far. And you see, we have 26% from African derived. We could do much better in American mixed race, I think that as we up the sample size, we put out another 200 letters of invitation. You don't get people coming over Christmas and holidays for research exams. So we're hoping in the new year to do more recruiting and bring in more people. But among what we can see so far is that the percent with primary open angle glaucoma in the lowest decile was only 4%. And those in the highest decile, it was 36%. And that the odds ratio after controlling for age, sex, genetically inferred ancestry, the odds ratio is 12.7. The confidence interval is a little unstable right now because the sample size is low. This is what we're seeing for African derived people. This gets to your question. 9.9. The confidence interval is just too noisy right now, but it looks like it's going to work. And for basically Hispanics, about 5.3. So the reason why I think it works in African derived people is because the score was created in a multi-ancestral fashion, not just in Caucasians. And so that's why it's working, but it doesn't explain why people of African ancestry are getting disease in their 20s and their 30s, because it's not like the score is higher in African. It's comparable to what we're seeing in Caucasians.
But can I just say something?
Please.
But maybe the New York population is very mixed. However, if you got data from go to Africa in sub-Saharan Africa and actually get from that population, you may actually get a different variation.
Absolutely.
Yeah,
Absolutely, it needs to be done, and isn't it happening?
it is happening.
Right, and you know, Mike Hauser is big on this, and you're working on it. You know, it's gotta happen, because if we could show this, who knows what we're gonna
Actually,
find.
the initial data they're gonna present in June.
Yeah, so I mean, really, it has to be done. You're right, there are probably other genes. And you know, people don't really understand this, but African people are the oldest people on earth. They're actually the most heterogeneous group of people on earth. They're not one group. There's no one who's one group. Caucasians are different groups, Hispanics are different groups, and so are African people are different groups. And there could be genes in different subpopulations of Blacks that are really important that we have no idea about them yet, and we got to go look for them. So you know, so this is exciting, and we'll have a further update if those of you who come to Seattle for ARVO to give it an idea of what's going on, what our update is. What I'm going to do now is I'm going to show you a patient from the study that we looked at to show you how glaucoma is behaving in this population. So this patient was referred. She answered our request for a survey. It takes about 2.5 hours to do these exams. We measure their blood pressure, their pulse. We do everything from soup to nuts on these patients. So she's 74-year-old from Haiti, no family history of glaucoma, not taking glaucoma medications. She has elevated cholesterol, but no diabetes or hypertension. Her vision's excellent. Pressures are in the middle normal range. Corneal hysteresis is 8.8. Her CCTs are unremarkable, the middle of the normal range, a little bit of cataract, open angles. Look at her optic nerves. And so you look at these optic nerves, they don't look that bad. Although there's some suggestion of a discoloration of the rim here and here. These aren't the greatest photographs, but you might say, well, you're biased. You're trying to find glaucoma in your study, you're trying to get results. By the way, when we look at these patients, we're masked to their genetic risk score, and they don't get graded until another doctor looks at all the information, and we come to consensus on a diagnosis of glaucoma. So we look at this patient's visual field, and by the way, patients who are naive to visual field testing, they don't do well the first time around. And so this patient has high fixation loss in the right eye, and in the left eye, reliability parameters are good. And but look at that. That looks very strange. That's kind of significant that could be glaucoma, even though this is a first-time visual field tester. And we saw Eileen's patient that had paracentral visual field loss. And by the way, 24-2 undersamples the central 10 degrees. It's only asking about 4 to 6 questions in the central visual field, and it doesn't take more than a few small saccades
for the patient to get a totally different retinal sensitivity in the foveal region, but yet that's where a lot of early damage is happening in glaucoma. Look at the OCT. If you just look at the, now you guys do a lot of serous here, I noticed. We do spectralis. And the reason why I like spectralis is because you get a really nice tomogram in the peripapillary nerve fiber layer. And you can really examine that very carefully. And so if you look at just this 4 segmentation plot, it's saying, well, this area is yellow. And if you look at the 4 segmentation plot of the left eye, it's normal. But if you cut it down further, there are these abnormalities and the classification is outside normal limits. But what I want to do is show you what I do is I could say, so here's the superior nerve fiber layer bundle where it's thickest. And I say, well, what's the comparable area in the inferior bundle? Look at that. That looks real to me. That looks like there's damage in that area. And that's concerning. You know, it's really interesting. We could do the same thing here and look at this. It's kind of this drop off here. Maybe that and this are adding up to glaucoma. So, you know, so this is how glaucoma is manifesting itself in these patients. So we also did a Brooks membrane opening report. And here again, we're seeing that there's this inferior sector abnormality in both the right and left eye, very localized damage in this region of the optic nerve. And so let's go even further. And so let's take a cross section from 2 o'clock to 7 o'clock of this optic nerve. And notice how the color in this area is different. And so this is the 2 o'clock area. This is Brooks membrane opening. And so you see a very healthy complement of nerve fiber layer tissue. But look at the area that corresponds to here. It's extremely thin. So this looks like real glaucoma. And we could do the same thing on the other side, left eye. Again, taking a cross section from 10 o'clock to 4 o'clock. And here's the same area. This is the 10 o'clock region. Good nerve fiber layer tissue here, but it's very thin here. So there's a very focal area here that looks like this is real glaucoma. Interestingly, we do OCTA on these patients too. And on the OCTA, we can see nerve fiber layer defects here inferiorly. And we're seeing a dropout of the superficial vascular density just in this area that's corresponding to the superior visual field loss in both the right and left eye. And we see it more clearly in the left eye. There's a nerve fiber layer defect here. There's dropout in the vascular density in the superficial region of that left eye. So after looking at this case pretty carefully, you see, you know, this is definite glaucoma. We've got a visual field defect in the left eye. We have OCT abnormalities in both eyes. I don't care what the eye pressure is. It looks like this patient has glaucoma. So maybe you agree with me, maybe you don't, but we came to consensus that this patient had glaucoma and their genetic risk score was 2.27, which was on the left side of that curve, which put them in the top 10 percentile for having primary open angle glaucoma. So if you still don't believe me, what I did was I called the patient back. Now she's my patient. I actually haven't started treating her yet because I want to see where her pressure is going to go. And I did a 10-2 visual field test. And you see the right eye looks full, but guess what? She's got a definite defect in the left eye. And now she's starting to get how to do visual fields. So this is definitely glaucoma. It's parametric glaucoma, not even pre-parametric. So what has we learned so far about how glaucoma is manifesting in when we call in patients this way? A lot of these patients have pressures in the normal range. You heard about a case of pressure of 42. That's not how these patients are presenting, interestingly. They're presenting with pressures in the normal range. And I'm talking about untreated patients. I think the highest pressure we've seen so far, like 22. And we do have to be careful when you see these dense defects that seem to be respecting the horizontal meridian, even in unreliable visual field tests. Bring the patient back, do a 10-2 just on that eye, so the patient doesn't feel like they're going through a major workout. Patients don't like to do visual fields. I'm sure you all hear that from all your patients. Oh, doctor, do I have to do the visual field test again? say, yeah, I want to just do it in this one eye, this separate way, it'll help us. And in this case, it did help us. And, we think of when I was a fellow at Hopkins and Dr. Quigley really emphasizes this idea, and it's correct, and Dr. Quigley's always correct, right? When you, in glaucoma, you get excavation of the neuroretinal rim, and it's like there's a little man sitting on the surface of the retina, and he can stick his finger underneath the neuroretinal rim. Yes, that is glaucoma, but our patient didn't look like that. It looked like an effacement of the inferior neuroretinal rim. And so earlier on, glaucoma has a different face than it does in this picture right here. Also, give credence to subtle inferior temporal rim changes and follow it up by really doing a deep dive into the OCT level data and get cross sections of the areas of concern. These images don't lie. And so when you see that Brooks membrane's here and the nerve fibrillar tissue ends there, that means there's real damage in that region. And so, look out for green disease. Everybody say, oh, it's green, it's good. Okay, green's not always good. Look at the tomograms and look at the cross-sectional data, because glaucoma is a very focal disease. Glaucoma is like a guy playing golf and taking a little divot out of the golf course. That's how glaucoma seems to start. So it's a very focal disease, and you got to look focally to find it. So I'll end with this. We have what, a few more minutes, I think?
Oh, yeah.
Okay. So this question's gonna come up. Theoretically, this glaucoma genetics risk score could be known at birth. This was looking like it's for real. It's definitely gonna come to, and I'm not saying the score we have is the final score. I think the score is gonna be modified over time. But the scoring is gonna come into clinical practice. You're gonna know people's genetic risk score, and it's gonna help you manage your patients. So when should we screen? When they're a baby? Of course not, because it's an age-related disease. But what we're finding, we looked in the UK Biobank to ask this kind of question: how does genetic risk scoring vary as a function of age? And it seems to be that the older you are, the better the scoring is. And so that kind of makes sense, that you got to wait a while, and that older people tend to have a bigger impact of their genetic risk score compared to younger people. And that's not true for all diseases, though, by the way. Here's the same kind of study for breast cancer, where they looked at the odds ratio for a genetic risk score for breast cancer as a function of age, and it doesn't vary. So every disease is different. And in fact, for colorectal cancer, it works the opposite way around, where the risk score that they've developed for colorectal cancer seems to work better in younger people than it does for older people. So not every disease works, the genetic risk scoring is working the same, but everybody, all these geneticists are doing the same thing we're doing, which is developing a polygenetic risk score for the disease and seeing what its clinical utility is. So the answer would be, just because you have a high score doesn't mean you have to go run into the eye doctor when you're 10 years old. But it's more of an age-related phenomenon. And then the next question is, can I get my genetic risk score? Short answer is no, because still research tool. But there is this thing called 23andMe, and you can get it for a holiday gift if you want. What they've created a score based on 8,000 variants. So our score is based on 114,000 variants. And their score is based on self-report of glaucoma. But the God's honest truth is those 302 genes that we've discovered for primary open-angle glaucoma, that was a pretty noisy definition of the disease. And it's really hard to sort of operationalize the hardcore definition for primary open-angle glaucoma. And self-report is not that bad when you have a large population of patients. So they'll give you a genetic risk score in 23andMe. And you might say, well, wait a minute, didn't the FDA ban them for doing this stuff? They did, but that was back in 2013 when they didn't have data. They now have data to show that their genetic risk score has some construct validity. And so like if it doesn't give you, absolute risk, it just gives you relative risk of getting the disease. But that's what we're doing right now. But what it will do is something like this. It'll say, Miss Jane Doe, your genetic risk is associated with increased likelihood of developing glaucoma. 44% of people with genetics and other factors like yours develop glaucoma by their 80s. And this is based on data from female 23andMe participants of Caucasian descent. So they've got millions of samples of patients. And so they're legitimate for saying this. And so this, if you live into your 80s, your risk of getting glaucoma, regardless of your genetic status, goes up to like 8%, 12%. So this is saying that this person has a 4-fold increased risk of glaucoma based on their genetic risk score by the time they're in their 80s. So there is some credence to it. So I wouldn't poo-poo it, but that's what's out there now. The poor man's version of this is just ask how many family members in your family have glaucoma. And I think 2 would indicate, if you have 2, a brother and a sister, that means you probably have a high genetic risk score, but we have to do more work to prove that. So in conclusion, primary open-angle glaucoma is a strongly genetic disease, and polygenetic risk score is approaching 80% accuracy and has clinical utility in disease management and screening. Of course, genes are not the entire explanation. And we need to also look at other factors that not only create the disease, but perhaps create disease resilience. Remember, I said in our study, we found that only 36% of people with the highest genetic risk score were getting glaucoma. Is that because we haven't looked long enough? Maybe. Is it because our genetic risk score is imperfect? Possibly. But is it possible that some of those people are harboring resilience factors that are preventing them from getting glaucoma? And so that's a question we can actually answer now that we couldn't answer before because we didn't know what people's genetic risk score was before. So, but more work needs to also be done to parlay all this gene discovery into better treatments. Because right now, you can look at all the randomized clinical trials you want. We don't stop glaucoma, we slow it down. It's not like, you got pneumonia, I give you an antibiotic and you're better. Optic doesn't make you better. It just slows the disease down. I'm not bad mouthing, Optic or anything like that, but that's the data. Any randomized clinical trial says that you slow the disease down and you don't stop it. But with all these genes, we should be able to figure this out and come up with better treatments. So I wanted to thank you for your attention. Be happy to answer any questions.
And also, but one of the things that you can also find is which genes are protected. And
Yes.
which ones are, because you may have a family that there's some that have disease and some that doesn't. So looking at why doesn't this one have the disease, right, is also good to discover protectivity. The other thing I wanted to ask you, OCTA. For patients that are pre-parametric, do you recommend that for early? Just not OCT, but OCTA? Because all of the literature is saying for pre-parametric diseases to do that, but I don't think we get paid for that.
We don't get paid for it. It's still a research tool. The evidence-based medicine is evolving, but I can tell you based on the 200 patients that we're looking at now, it seems to be something that's happening. OCTA dropout of vascular density in the superficial retina seems to be happening around the same time as the neurofibrillary tissue is dropping out. But this is cross-sectional. I don't have longitudinal data either. But based on what my gut impression is telling me, it's happening simultaneously with dropout of neurofibrillary tissue. And really, OCT is a blessing for us. It's just an incredible benefit to our field. We got to look at that data more carefully because there's a lot of information in there. And as I showed you in that Haitian lady, you got to really look at it carefully. Sometimes it's an artifact, but a lot of times it's real and it's telling us stuff. And based on that patient, again, that's his, this isn't going, I'm trying to go back to the patient's data to answer your question about OCTA, because if you remember, this thing just isn't going so fast. But basically what it was showing was that there's subtle neurofibrillary dropout and there's subtle OCT dropout, right? And it's in that quadrant there, and the OC, come on. It's like a watch pot, never boils.
And also the macula too. Also the-
Yeah, macula is really important. But I want to get to it for.
That's-
Okay, but the point is that it's happening around the same time. That's what it's looking like. I don't find, in fact, we don't use, so the way we come up with the diagnosis in our study is, again, we're masked. We look at all the data. We try not to weight anything any more than another thing. But we're finding that the OCT is the most helpful for making the diagnosis in the cross-sectional study. And we're not even looking at the OCTA because we don't even know what we're looking at yet. You know, but at some point we'll get there. Other questions? Yes.
You've done a lot of work with non-genetic factors, environmental factors. Have you ever thought, you've probably already tried getting a risk factor that includes all the other things you've looked at, exercise, smoking, alcohol?
Yeah, that's a great question. Yeah, and well, you know, that's why we got into the genetics, because we didn't find a lot there. But what we're doing in the nurses' health study and health professional follow-up study, where we've genotyped everyone, we have all the environmental factors, is we're doing metabolomics and proteomics. And we want to create a multi-omic framework and find out what are the metabolites associated with a low and a high genetic risk score, because metabolites are a reflection of your environment. Proteomics as well. So we want to look at proteins that are different between the high and lowest genetic risk score. So one of the research things that we're doing right now, I have a student at Mount Sinai who is going in the UK Biobank, where there's self-reported glaucoma. They have genetics and they have metabolomics to create a metabolite risk score for primary open-angle glaucoma and see how predictive of the disease it is and how that compares to the polygenetic risk score. Is it better? Is it worse? And then when you put them all together, does that improve the accuracy versus looking at each one apart? I think that, you know, looking at the environment is great. I mean, I've done it for years and NIH supported me for doing it, but it's kind of noisy and it's better to look at hard numbers. And I think the metabolites could help us do that. Yeah.
You touched on kind of some of the genes associated with like treatment resistance as well. Have you found or plan to study any particular genes that may be associated with resistance in particular classes of medications? Things like that?
So you need probably more than 800 patients to do that, but it's definitely something we want to do. And Sai Marai, actually at Ohio State University, who's not far from here, she's really interested in that. She's been interested in that from 10 years ago, maybe 20 years ago. It does need to be done. But what I want to do is to say, do the genes point to new drug targets? That's what I want to do. And one of the papers I published was like looking at the genes associated with smoking addiction and genes associated with glaucoma. You know what? The genes associated with smoking addiction are actually protective for glaucoma. And so there must be something in there with nicotine or some kind of addiction behavior biochemistry that's a better drug target for glaucoma than latanoprost and alphagan and all the stuff that we're using right now. So, good question. And yeah.
Yeah, so I had a question about the vascular associated components.
Oh,
with
yes, thank
OCTA. And so, you know, there's gaining interest that that the OCTA can be predictive of the regional loss that might be at a predictive score for not only who's going to advance, but where they're going to advance, where the defects are going to be in the future. So my question is back to the genetics, like in most of the genetic panels that you showed us, I didn't see any factors that related to vascular known factors. So the question is, do you think that this associates by correlation, that it's still primary RNFL loss and secondary vascular defect? Or are there some vascular genetic factors that can be driving the progression of disease?
Well, yeah. So when I wrote my first NIH grant, I said, this was pre-GWAS, I'm taking a candidate approach. I believe it's vascular disease, and NOS3 is the answer to everything. And of course, that's stupid, but it did get me a lot of mileage because it is important in the disease. So, you know, and I do believe that's why people are spiking early in the morning. So NOS3, it doesn't show up in any GWAS, but Evelyn does. That's one of the first hits for primary open angle glaucoma. Evelyn sits right next to MOS3 on vascular endothelial cell membranes to mediate endothelial cell relaxation. So there are actually a lot of vascular genes in there. And actually the estimate is that 70% of the genes that we're finding have some connection to vascular function. It's complicated, but it definitely vascular factors are playing a role. And there Lucy Shen at Mass Eye and Ears very interested in developing a modified version of the glaucoma genetic risk score, focusing in just on the vascular genes that we know that are in that list of 300 and see how that correlates with OCTA. So yeah, I think vascular, I mean, when you look at all the genes, we're not finding primary neuronal markers. We're finding extracellular matrix, we're finding vascular factors, we're finding, you know, ECM related factors. But yeah, I think vascular factors are really important. That's why we're doing the OCTA and hopefully we'll go back and redo genetic risk scores and refine it a little bit more to see which are the genes on the vascular side that are contributing to the disease. I mean, when I started out at Mass Eye and Ear, we made a vascular assay for glaucoma. So we used something called a Cannon Doppler blood flow meter, which can zero in on a vascular segment and measure the blood flow, not the velocity, the flow. And we did it with the patient sitting up, and then we laid them down and we did it again. And we sat them up again. And when you lay patients down with primary open angle glaucoma, the blood flow goes through the roof. It's not what you think. It's the vessel behaves like a passive sieve. It's not responding to the factors that should cause it to auto-regulate. And we showed actually that brimonidine reversed that. And brimonidine increases nitric oxide signaling. And I could go on and on. I don't want to talk about an hour about that, but it's a passionate subject of mine. I do think vascular factors are important. That might be why a lot of these patients have normal pressure, because vascular factors are important. Anything else? Well, I want to thank you again, and thank you for inviting me. This has been a lot of fun.
Thank you for that great presentation and present you with this to commemorate your lecture here in the Disney Professor Series.
Thank you very much.
Thank you.